Okay? All right, so folks going up to the mics, right?
Yes.
All right, so acetaminophen Tylenol primarily exerts action in the CNS, resulting in net effects of what actions?
I believe that would be analgesic and antipyretics.
Perfect. All right, sure. Sophomores 1, juniors 0, right? All right, true or false? Acetaminophen Tylenol carries boxed warnings for increased risk of GI bleeding and cardiovascular risk.
False.
Juniors very confidently said
False.
false. All right, number 3, if we want to get someone ready at the mic, don't answer it yet.
Minus 1 point.
All right, this is Jeopardy, right? That we need to wait till the answer's done. Venlafaxine or Effexor is an SNRI that is useful in chronic nociceptive and neuropathic conditions.
True.
What is true? Wrong answer.
All right, question 4. TCA should be used cautiously in many patient populations and are contraindicated if what?
If you got heart issues,
What specifically?
specifically MI.
Perfect. All right. Anticonvulsants here, primarily going to be useful in acute or chronic pain conditions.
Chronic. And
Nociceptive or neuropathic?
neuropathic.
Neuropathic. All right. Sophomores seem pretty confident, you guys. All right, moving on to muscle relaxants. Cyclobenzaprine or Flexeril exhibits anticholinergic effects, and it's an analog of diphenhydramine or Benadryl.
False.
We got false over here. All right, baclofen works as a what type of agonist? And is it used in spasms or spasticity? Okay, juniors are feeling confident with spasticity. Okay, we think of MS, right? That answer is given to you, that it's for MS. You think of it for spasticity.
What?
We're going GABA.
GABA.
Is it GABA A or GABA B?
Yes.
B. So baclofen is one of our very few that is GABA B. Our benzos, barbiturates are going to be GABA A. And then we want to make sure that we're in close monitoring our tizanidine or Xanaflex because it could cause rare but clinically significant what type of toxicity?
Hepatic.
Perfect. All right, they can't even see me and they just know. I'm looking at them. All right, some of our other agents, we have an NMDA receptor antagonist. They inhibit glutamate binding. Is glutamate excitatory or inhibitory? Excitatory, perfect.
Excitatory.
Yes. All right, and then we want to result in either the increase or decrease of action potential with that.
Decrease.
We will have a decrease in action potential, and then how about our pain signaling?
It decreases.
Perfect. True or false, ziconotide or Prialt exhibits or inhibits action potentials via calcium channels and is administered via an intrathecal pump only. True. Good.
False.
So ziconotide is going to be true. We love the effort. The juniors are so proud of the effort that you gave on that one. All right. We also talked about opioid overviews. We'll finish the rest of today on the remainder piece of opioids. So long-acting opioids provide basal or bolus analgesia. Basal, good. And it's often through an around-the-clock or ACT dosing approach. They should only be considered in patients that are considered what?
Tolerant.
Yes, opioid tolerance. And then which setting should opioid therapy ideally be limited to?
acute,
Yep, severe acute pain or procedural pain.
and chronic.
Incorrect.
Malignant, I said.
Yes. We saved ourselves. Perfect. Yep. So cancer-related, moderate to severe pain for cancer. Okay. All right. The remaining ones are going to be covered in the rest of today's content. Depending on how we do today, we may or may not get that one. All right. All right, sophomores, everything looks good still? New slide deck? Okay, perfect. All right, so as a reminder, we started yesterday talking about opioid-related side effects, some of the tolerability concerns. We talked about both the common ones and more of the long-term ones, how we might consider mitigating those, and then we talked about a few examples and what those management approaches might be. We met Harold and we left off starting with our precautions. So when thinking about opioid therapy, we also need to be cautious in folks that are pregnant or lactating. We need to think about patients that have impaired pulmonary function. So we talked about the risk of respiratory depression. So if we have some sort of pulmonary concern, we want to be cautious with those folks as well. And then patients that have head injuries is a unique one. So when we're thinking about some of our trauma folks, this can also come into play. In pediatrics, there's two agents specifically that we want to be really mindful of, so codeine and tramadol. They are both go through metabolism via 2D6, and that 2D6 in folks that have a ultra metabolism pathway, now they get extensive amounts of their active metabolite, that is 300 plus more times more active than the pre-drug, that prodrug there. So for codeine, any kiddo that is less than 18, it's a boxed warning for any sort of oral type procedures. There's contraindicated with tramadol in that same population, and then contraindicated for any kiddos that are less than 12 for both of those agents, and then being cautious in those that are 12 to 18 that meet higher risk population, so obesity, sleep apnea, different lung diseases. Oh, I skipped a slide. Also cautious in renal and hepatic impairment. So remembering that all opioids do carry risks for both renal and hepatic, but how they're metabolized may change that as well. Some are certainly going to be more significant than others, which is why we always pick opioids and we start low, we go slow, we titrate based on that response. And then we can see two different tables here. So this is from Goldstein. And so we see opioids that are favorable in kidney, unfavorable in kidney, and then those that are favorable in hepatic. Which one is preferred in both of those? Fentanyl, yeah, right? Process of elimination, there's only one that's preferred in hepatic, so is it in the other column? Yes. Okay, and then which one's not preferred in both of them? Codeine, right? So if we have little Milo, right, he's our 10-year-old, he's getting that dental procedure done, and he's gonna have that severe pain, and so we already said earlier that he is an appropriate candidate for opioids, right? He has severe acute pain, it's gonna be severe, we want to help him, give him some opioids. What are things that we need to be thinking about? Just any opioid we want? Milo's chill, he can handle it, right? Any things that we just talked about in pediatric patients that are getting oral surgical operations done? Come on, juniors. Gotta give me something. Can't do tramadol or codeine. Okay? So remembering, right, that 12 cutoff, that 18 cutoff, what are those different stipulations or risk factors and why that is? Our opioids also have a lot of, it has a REMS program, which means that we just have to give a lot of information. So the manufacturers are required to monitor and do a lot of education to providers and make sure that that is transferred over to patients. And then there's a ton of boxed warnings. So addiction and misuse, respiratory depression, accidental ingestion, neonatal withdrawal syndrome. So that's when mom is taking opioids and then babe is born with that withdrawal syndrome. And then anyone who's taking that concurrent CNS depressive risk, things like benzos or alcohol. And then there are specific box warnings for each separate agent based on which CYP inhibitor that specific opioid is involved in. I'm not requiring that you guys know specifically that fentanyl is this and all these other things, other than the two that we already talked about, right? So that codeine and tramadol. All right. There's a few definitions that we think about with opioid therapy. We can equate this to other medications as well, or substances such as caffeine. So 3 definitions. Tolerance is going to be a reduced efficacy over time, okay? So I think of this as, you know what, my daily 2 cups of coffee aren't giving me that same benefit. It previously was really great, but I think my body's gotten used to it. So either I need to increase that amount to get that same baseline, or I need to do something else, right? Switch to something else that's a little bit more powerful or something else. Dependence is when you are stable with the medication dose, and if you go without it, you could have withdrawal, okay? So I always have this much coffee a day or this much tea a day, and if I don't, I am horrible. I can't do anything, I can't function, I am withdrawing without that. And then addiction and misuse is using a substance despite the negative outcomes and harmful behaviors or cravings. So again, I'm always late to work, I skip meetings because I'm preoccupied with trying to obtain coffee, I drink coffee within 6 hours of bedtime, so on and so forth, right? So those would be things that are potentially not appropriate despite those negative outcomes. There's different things that we can do to screen for potential misuse of opioid therapies. So things like toxicology screens, these are often going to be urine tests. We can also do blood tests as well. This will tell us whether there is presence or absence of a substance in the bloodstream or in the urine. We could do a prescription drug monitoring program. Who has heard of the PDMP? Show of hands. Very few. Sophomores, anyone? Very few, okay. So the PDMP is a database that pharmacies are required to upload recent scripts of controlled substances. So it just tells you, you know, Jane Doe picked up a tramadol, quantity 30 on this date from this pharmacy from this provider. And so it's a helpful tool to give you all of that stuff. It tells you how they paid for it. So did they pay with insurance, workers' comp, TRICARE, Medicare, Medicaid, or did they do a cash payment? The downside with PDMPs is they don't tell you the SIGs, so you don't know how they're supposed to be taking it. All right, medication availability. So what is a physical pill count? You can have them bring in their pill bottles or patches and do an actual count to figure out how they're using it or potential misusing it. Opioid agreement or sole providers are contracts that just say that we're going to use these medications safely, we're not going to divert them, we're not going to give them to others that they're not prescribed to. And then we can also do other types of screening. So these are subjective screenings. The ORT is objective. We at BAMC don't use it. It's not our standard. But these are validated questionnaires that either we can use or the patients, and it tells us what their risk is of having some sort of opioid misuse with their therapy. If folks do have opioid use disorder, defining what...
Our meeting disconnected. We're trying to get back on right now, so people are trying to follow on. Just heads up.
Thank you.
We'll thug it out. You can continue.
Okay. Power on. All right, if we need a pause, let me know. So I'm on slide 250 here. So opioid use disorder treatment approaches is we're going to pick one of these options. If someone has opioid use disorder, the appropriate FDA-approved options are going to be one of these three. Methadone is going to be a mu receptor agonist. We'll talk about all of these agents specifically in the next slides as they come up. But these three agents, so methadone is a controlled substance 2. It is going to be working at that mu receptor. It does also have an NMDA, right? So that revving or that race car type picture, it's going to help suppress that process. Methadone is considered a prescription alternative. So if someone is using or misusing oxycodone or fentanyl or heroin or whatever, methadone is just a way to replace that, okay? So we're solely replacing it 1v1 with something that's prescribed. Methadone for opioid use disorder is only available through specific outpatient treatment programs. So if you are working in a pain clinic and someone has opioid use disorder and they solely need methadone for opioid use disorder, you cannot prescribe it. They have to go to an outside treatment program for that. The reason for that is to have close monitoring, okay? Buprenorphine is a C3. Buprenorphine you'll see either by itself or with naloxone. Either have indications for opioid use disorder. It is going to be, like we talked about previously, that mu receptor and then also that kappa inverse agonist. Buprenorphine is considered that safer prescription alternative. So we're going to have that respiratory effect ceiling because of that partial activity, right? So instead of both of those doors opening, we're just getting one of those doors. We used to have limitations. Congress reversed it back in late 2020, and actually next week they're formally reversing it. I believe there was some sort of executive order that was recently signed this week. That next week it will be final. So any person that has a DEA license can write for bup. There's no limitations there. And then naltrexone is just a mu receptor antagonist. So we are solely sitting on that receptor. This is going to be helping with suppressed cravings. So we're not helping replace anything that they were misusing. We're just blocking that receptor and suppressing the cravings that they were having because now we're occupying that receptor there. Usually we give this as a once a month injection intramuscularly, and the patient can't currently be using opioids. Otherwise those opioids aren't going to work. So going a little bit in depth onto the next slide here. We have naltrexone. It's going to be a central mu receptor antagonist. Labeled indications, we can use it for opioid use disorder. Orally, we can use it for alcohol use disorder. It is a little bit more costly, so about $2,000 a month for that injection. When we start naltrexone, we need to make sure that we're waiting at least a week to 2 weeks following the last dose of opioid. So if someone was using fentanyl or heroin or oxycodone, we need to make sure that we're giving enough of a window for those patients so they're able to fully withdraw from that other opioid and detoxify before we completely block that receptor. If someone is going to get surgery, we need to make sure that we are effectively offering appropriate pain management for that surgery as well. So whether that's oral, we need to stop it at least 3 days before. If we're doing the IM injections, we need to stop it a month before. If folks are getting these injections, you might consider that they get a medical bracelet or some sort of alert because if they're in the field or if something, they're in a car crash, anything like that, and you try to treat them with traditional opioids, it's not going to be as effective for them because they have this blocker that's in their system. Brief pause. It's uploaded.
It's the
I emailed it on Wednesday. Last week. Okay. All right. So if we have Tony, he is our 75-year-old male patient that was newly diagnosed with metastatic cancer. He's been offered opioid therapy to manage his severe cancer-related pain though he declined, stating, "I don't want to get addicted to that stuff." So the first question is Tony an appropriate candidate for opioids? Yes, no? Yes, according to what? Severe metastatic pain, which uses which tool? Yep, that ladder, right? So close enough, good. Climbing up that ladder, he can get opioids. What do we think? Do we think that Tony's gonna get addicted to opioids? He could. Which definition do we think he's most likely to have or experience? Dependence and tolerance, right? He might get used to it and he might need a little bit more in a couple months, and he might need a little bit more in a couple months, right? So that's tolerance. And then that dependence, if he were to ever miss doses, he might feel withdrawal, okay? So a lot of my education, this is a weekly, if not daily occurrence for me, a lot of my education is about the difference between those definitions. What tools might we monitor if he were to develop a misuse? What things could we tell him that, you know what, if you're worried about it, we can do things. We can monitor things. Okay. Screening tools. We could do a database, see if he's doctor shopping or pharmacy shopping. We could do pill counts. What else could we do? Questionnaires, PDPs, what else? Contracts. Yeah, we can monitor how much drug is in his body, right? Making sure that it's the right stuff. All right, next patient, Miss Kenzie. She's a 30-year-old female newly established with your clinic. She has untreated opioid use disorder and is interested in trialing something to help mitigate her ongoing cravings. So she has opioid use disorder. The guidelines say that we just have to pick one of them. Okay, so we could either just replace whatever she's been using, we could use a safer option, or we could just focus on the cravings, right? If we pick I would say the more medicated opioid-based products, they're still going to treat the cravings, but they're also going to offer additional benefits, right? So there might be questions that we want to ask her, okay? So what question might we want to ask if she wants to use methadone? What's a big stipulation with that one? Yeah, so you have to go somewhere else every single day. Okay, an intensive, this outpatient treatment program, you literally go in, they give you like a shot of Kool-Aid essentially, and then you chug it in front of them. They're like, great, see you tomorrow. Okay. Buprenorphine. Yes, no, maybe? Potentially. Okay. Naltrexone. It's expensive, right? So what's her insurance look like? When is the last time she used it? And then does she have any anticipated future need for opioids, right? If she has sickle cell disease, probably not going to be a great option when we're using those types of products in sickle cell. If she's a stunt double and constantly breaking bones, probably not a great option either, right? All right. So clinical pearls on this section, remembering that tolerability concerns with opioid therapies are common and should be managed with appropriate means, either dose reducing, rotating, or adding something else. Opioid therapies are impacted by renal and hepatic function. Tolerance, dependence, and addiction are key definitions when we discuss these controlled substances. And then those that develop opioid use disorder should be appropriately managed with a treatment approach that aligns with their situation. All right, sophomores, how we doing?
Wonderful.
Doing great. I see the screens are no longer working, but we're fine. Okay, love it. Love it. Okay. All right, moving on to opioid safety. So slide 260 here. 261. So here we see kind of the course of opioid use. So as we take an opioid, if we take at the very bottom corner here, We take some opioid, we go up this curve, and these are some of the symptoms that we could develop that would signify intoxication, and then at some point overdose, which is going to be that slow, shallow breathing, potential coma, and then death. Okay, so opioid safety, we die with overdose. When we stop opioids, so this is kind of where the curve comes back down. If we stop opioids or if we add an antagonist, now we get this withdrawal or this detox effects. And so these are all the symptoms that we see here. Next slide. So opioid therapy is fatal in overdose, not withdrawal, as I mentioned. Things that might be indicators are, again, that respiration change, that difficulty to arouse. They can have pinpoint pupils, specifically with that mu receptor, and then blue lips and fingertips. Opioid overdose risk factors, so people that are more likely to have a risk of overdose in the future are going to be folks that have any historical intoxication or overdose among any substance, historical substance use disorders or illicit drug use, if they're taking concurrent CNS depressants, if they have an increase in their dose, any respiratory compromise, and then that renal hepatic impairment. So we can try to blunt these effects with that next slide here, opioid antagonists. There's two main ones that we're going to use as a rescue here. So either naltrexone or naloxone or nalmefene. Nalmefene is limited to those that are 12 plus. These are going to be central mu receptor antagonists. We're competing for that receptor. We're trying to get that other opioid off the receptor, and we're just trying to occupy it. So we're not trying to get that respiratory change, just occupying it. No action is going to be happening there anymore. Primary uses are going to be for rapid opioid reversal. We want to proactively be prescribing these agents for these patients. One way that you can consider discussing with patients is describing it like a fire extinguisher, right? We hope you never have to use this. We hope you never use your home fire extinguisher. But if a fire were to happen, it's nice to have, right? So same thing here. I previously was at the VA. A big way that I was able to get a lot of my vets to agree to get Narcan is what we were doing there, was to say, you know what, do you have a dog? If you ever dropped a pill on the floor, or a couple, and they got into, your fentanyl patches, you can use this, okay? So anything that has a mucous membrane, you can use the nasal spray, and then certainly IMIV you can give as well. Your side effects with these agents is going to be opioid withdrawal, right? So we're taking that opioid off the receptor. We're now going to have all of these withdrawal effects. The next slide here is the approach that we use with nasals. So these are just nasal sprays. This is what they look like. Has anyone had to use one of these before or played around with one before? Okay, a couple hands. So these ones are kind of a plunger on the bottom. So you put your fingers on each side of, let me get a laser pointer here. So you put your fingers on each side of this here. This top piece in that picture is placed into the nostril, and then you just push up on that bottom piece. First step you're going to do if you suspect an opioid overdose is you are going to evaluate your patient, right? Hey, how you doing? What's going on? Are they having some of those symptoms of opioid overdose there? We're going to administer that first dose, so we'll peel it out of the packaging. We will go ahead and press that bottom piece there. We'll plug that one nostril as we instill that dose. And then we will then call 911 is going to be our third step. 2 to 5 minutes later, if we need to repeat doses, we will then take a new nasal spray and then place that dose in the next nostril. If at any point you need to do CPR, right? Slide 265 here, so opioid risk mitigation. Too many mics here, okay. Opioid risk mitigation. So Safe storage, so making sure that patients are using a lockbox, so storing them safely up on higher shelves away from children and pets. Disposing opioids, so the environmental agency has actually approved opioids to be disposed of by flushing them down the toilet, okay? So if you have a fentanyl patch and you want to flush it down the toilet, please do. It has been approved. It should not be thrown in the garbage. There have been many case reports of children and dogs getting into the garbage, playing with a fentanyl patch, putting it on their cheek, and they die, okay? So fentanyl patches, all tablets, any sort of solution, they should be flushed down the toilet, or they should be placed back into the lock box in a disposal section, and then that should be brought in and disposed of. Most pharmacies have take-back bins, where it's similar to like a mail carrier bin, where you just throw in the medication and then you can't retrieve it again. And then those all get incinerated. Okay, so they can keep their patient label on things, that's totally fine. We, again, could do opioid agreements and sole providers for that education. There's a unique screening tool here that we could do called the REASORD. This is a standard for us within DHA that we do. This helps determine the likelihood that someone would have an opioid-related respiratory event in the next 6 months. And then we can certainly give them that fire extinguisher, so that naloxone or nalmefene. So next slide, we have little Felix. He is our 6-year-old. He has no pertinent past medical history, and he was found down. He has weak pulses, slow and shallow breathing, and cyanosis of his lips. There is a known family member in the home that is presently receiving the support of hospice and is requiring concentrated oral morphine solution. What could be happening with Felix? Potential an overdose, okay? How would we want to manage this? Yeah, Narcan or naloxone. What else? What's the other one? Rescue breathing. What was it?
Stand by for rescue breathing CPR.
So Narcan and naloxone are the same thing.
We can't use nalmefene, he's under 12.
Perfect, yeah. So because he's 6, we technically shouldn't do the other one. My bias is, right, this is Nicole's personal opinion. I would, nalmefene has a much faster onset of action. Narcan, how fast do we think it works? When nasal, right? I know some people have probably given IV. Okay.
Is it over the counter like?
Yeah.
Is it over the counter like Narcan, or is it just in hospital?
So, a couple points here. So, we have one guess of 2 minutes. Let me come back to that. Other thoughts on how fast it starts working?
Oh, it's like seconds.
So the studies show about 10 to plus minutes, okay? 10 to 15 minutes for that onset, okay? If it was my kid, just because it hasn't been studied in under 12. So then the other question is nalmefene, is OPVEE available over the counter? It is not. Not that I've seen yet that it hasn't been approved. So naloxone or Narcan has been approved for over-the-counter use. You can buy it at any pharmacy. Patients report it's roughly anywhere from $20 to $60, depending on where they're going. Okay, so little Felix, we're going to go ahead, make sure that, hey, are you okay, right? Love that simulation.
Question.
Yes, please.
So, can you give too much naloxone?
Love that question. So what do you guys think? So question is, can you give too much naloxone? So we'll do a show of hands, either yes or no. Who says yes, you can give too much? Who says no? Okay, so this is a loaded question. Theoretically, the dose makes the poison, meaning you theoretically could give me, I don't take opioids, you could give me millions of grams of Narcan, and yeah, that wouldn't be good for me, right? In the setting of opioid overdose, in the setting of life and death, in the setting of little Felix, we can keep pushing doses, right? other questions? Got that one. Yep. All right, we got a question here coming up to the mic.
Ma'am, just to clarify, in the setting of a patient who's opioid dependent, and they're potentially overdosing, too much naloxone could kill them, kicking them into opioid withdrawal, rather than if somebody is not opioid dependent and we give them too much naloxone, that won't necessarily kill them. Is that an accurate statement?
So in the setting of withdrawal, they will feel like they are dying. They will not die in an appropriate range, right? So don't give them millions of grams of it. But if you continue to repeat dosing, they're gonna feel like they are dying because they are dependent to it. They have a tolerance to these things, right? If their goal is to not die and they're gonna be in pain, so there are cases where we do give too much, in a sense, too much, where we're getting too much withdrawal symptoms, that we do start supplementing with opioids again. It's a balancing act. Naloxone has a very short half-life as well, so about 30 minutes to 2 hours is its half-life. So most of our opioids are gonna work much longer than that window, and so we do have to usually repeat dosing. Good questions. So really, to the withdrawal comment of can you die in that setting, really the only documented cases are gonna be in neonates for neonatal withdrawal. Okay, and that's just because they don't have the ability to self-soothe, self-stabilize that difference. Okay. So what does withdrawal look like? As we kind of mentioned, so this is slide 267. Non-fatal, it's going to happen with an abrupt discontinuation or a significant reduction in dose. These symptoms can persist for days to weeks. Those that have unmanaged withdrawal symptoms are at a higher risk of having a relapse in the future. So folks that have, oh, I missed my meds, I'm going on a cruise, I forgot to pack them, it's fine, I'll go without them. If they experience a withdrawal once, they're more likely to overdose and have a relapse in the future. How do we manage withdrawal? So kind of as I alluded to, we can replace the opioids, so we can give supplemental opioids to try to do that. In the chronic patient who we're just trying to get off of medications gradually, we don't usually want to give them more opioid in that setting. Usually there, we're gonna do some sort of symptom management or supportive care for whatever they're experiencing. So if they have some diarrhea, if they're irritable, if they can't sleep and have insomnia, then we're gonna treat those things with other medications. So our clinical pearls now are going to be that opioid intoxication and overdose must be promptly identified and managed with a central opioid antagonist to minimize that advancement to death. We want to make sure that we have different risk mitigation strategies to identify those that could have that increased risk, and then making sure that opioid withdrawal is poorly tolerated and may persist for days to weeks. All right, sophomores, can you confirm you can see my slides now? Beautiful, love it.
Yes, ma'am.
Thank you. All right, so now going into some of our opioids. When we think of opioids, and why I usually say opioid instead of opiate, there's a difference between what those terms mean. So opiates are derived from those things that are related to opium, okay, or morphine. So anything that is most opium or morphine-like is going to be an opiate. Opioids involve opiates as well. Try and guess, okay. Opioids are going to be anything that resembles it and has that same addictive and psychological effect as opium, but is not necessarily derived from it. So here we see different classes and different structures of our opioids. So morphine structure here, and then it kind of differentiates into other types and classes of opioids as well. And then the most, or the least opiate-like in this morphine group are all the ones that have asterisks. In our next slide, it will distinguish this better for you guys. When we think about our opioids, we also need to be cautious and mindful as to how each of them are related. So many of our opioids are actually metabolites of other opioids. So here we can see that codeine metabolizes to morphine. Morphine then metabolizes to hydromorphone. Codeine also metabolizes to hydrocodone, and hydrocodone metabolizes to hydromorphone. Okay. Heroin goes to 6-AM as a unique metabolite, and then that goes to morphine. So if you want to confirm that someone has been using heroin, you specifically need to get a 6-AM metabolite. Okay. All right, this I have abbreviated in this H to 6-AM to M mnemonic here on the side. This is also alphabetical. Okay, so C's always go to M's. Codeine goes to morphine, hydrocodone goes to hydromorphone. Everything always gets hydrolyzed, right? C gets an H added onto it. M gets an H added onto it. Yes, no, makes sense, feels good. Okay, feeling good? Pathway never goes backwards. Okay, so if someone takes hydromorphone, they only have hydromorphone in their system as far as these chemicals go, okay? So if someone only has hydromorphone, they should not have morphine in their system. They should not have heroin in their system, okay? We can do tox screens. So this is where this knowledge comes into place. We're messing around with my sound, I see. Okay. So we do need to make sure that we're asking about the last dose and then the total dose that these folks have been taking to confirm these tox screen results. Here are our opioids again, and then many of them have inactive metabolites, and then many of them have active metabolites, as we showed on the last screen there. And then we do have other active metabolites that are not pharmaceutical opioids that are also present. The only two that do not have any active metabolites are fentanyl and methadone. Okay, so if those agents are not metabolized, if you give an inhibitor of their CYP pathways, what's going to happen? So the end result is death, because why? Yeah, so we're no longer metabolizing. Okay, if I take fentanyl and fentanyl doesn't metabolize to anything else, and now I block how it would get metabolized to something that's inactive, now I'm getting more and more and more active fentanyl built up, right? I'm increasing my risk of death. Okay. These are just little summaries of which agents are 2D6 and 3A4 and kind of where they fall as far as agents that we've talked about throughout the lecture. So let's run through two cases here. So if we have Edward, he's our 45-year-old patient. He got a short course of tramadol for acute pain, and he was notified by his employer that he was randomly selected for a tox screen. So the Federal 5 is a common tox screen that we'll do, and these are the agents that it looks for. So it specifically looks for opiates, marijuana, cocaine, amphetamines, and then PCP. And currently his results are pending. What do we expect that they're going to show? So we're going to do show of hands, either positive or it's going to be present or not present. So show of hands for who says that opiates is going to be present. Okay, who says not present? Okay, so more hands for not present. What is the caveat with this? Okay, so tramadol is considered more of an opioid. It has the same effects as morphine, but it doesn't look like morphine. Okay, so it's not an opiate. So that's a very unique caveat, but something that we see often is folks will be, oh, no, I'm so worried, right? This is going on, or I got this, like, you're fine, right? It doesn't look like it unless they specific. So we could on Mr. Edward, we could get a tramadol screen, and that could then be present, right? So we can specifically get a specific drug rather than an opiate screen. All right, and then one last one here, and then we'll take a break. So Marissa, she is our 40-year-old female. She is receiving chronic opioid therapy with methadone, 10 milligrams 3 times a day, and oxycodone, 5 milligrams Q4. She got a urine tox that has the following results. I did not talk about oxy, I deleted that slide. So oxycodone, what do we think it metabolizes to? Oxymorphone, so it follows that exact same principle as your C's go to M's. So again, oxycodone would metabolize to oxymorphone. So we do see oxycodone is present. We also appropriately see that oxymorphone is present. We see that methadone is present. Should fentanyl or tramadol be there? Should it be present? No. Okay, so those two are appropriate. Morphine is not detected, and then hydromorphone is detected. So is hydromorphone appropriate? Should it be there if she's on oxys and methadone?
Oxy doesn't metabolize into.
Nope, good question. Yeah, so question being, does oxy metabolize over to that? It does not. So it shouldn't be there. What could Miss Marissa have taken to get that positive result? She could have taken hydromorphone. Okay, I have a question of codeine. So could codeine have been taken? So codeine will metabolize to morphine and hydrocodone first. Morphine is not detected. Okay. Theoretically, she could have taken it and it could have been days ago, and so now we only have that final metabolite. So this was a case that did come up in our clinic, and yes, patient had gone to an ER a couple days before and got some Dilaudid. So that's your hydromorphone there. So, all right, let's go ahead and break, and we'll come back right after the hour here. Our next one, codeine is one of our cough agents. We remember our cough agents with codeine and hydrocodone. Again, this is just going back to opioid mechanisms. Some of them do have cough benefit given that respiratory pathway. Codeine's controlled substance class depends on what it's combined with. So codeine by itself is a C2. With Tylenol or acetaminophen makes it a C3. I remember this because its brand name is Tylenol number 3. And then codeine with guaifenesin, when it's used for cough, is going to be a C5. Codeine primarily is going to have a weak action at that mu receptor. It's less potent than morphine. Primarily, we're going to use it for pain and then as an antitussive. Consideration, so interestingly, we use it for cough, yet for those that have acute and severe asthma, we do have a respiratory irritant in its formulation. So I always think that's interesting. If their cough gets worse, maybe it's actually from the drug. And then we do have hepatic metabolism, as we've already talked about a couple times here with that 2D6, and it is metabolized to morphine as well as hydrocodone. And then we do have that box warning. When we think about morphine, this is a C2. It's primarily going to be that mu receptor. Morphine long-acting tablets look like Skittles. This is a helpful thing if you're giving these therapies to a young parent and they have kids around and they want to try some of, mom's Skittles. These come in oral formulations that are both short-acting and long-acting, and then a variety of other routes as well. MS Cotton is one of the brand names that we are not to use per the Joint Commission, and that is just because MS can be confused with either morphine sulfate or magnesium sulfate. Considerations with this one is one of our agents that we have the highest risk of rash and some of that histaminic response. More of that GI and CNS depressive concerns are also more prevalent. Morphine, and then we'll talk about hydromorphone. They have these additional metabolites that are active that cause CNS-related side effects. So these are the things that increase your pain. So too much morphine can actually increase your pain with this metabolite of, it's called M3G. M6G is good for pain, and then again, hydromorphone, its metabolite, is also going to be helpful for pain. Hydrocodone, we'll jump back to this one first. Again, it's another one for cough. It's equally as potent as morphine is. And then it has multiple different combinations. It is always combined with something in its immediate release formulations. We do have an extended release, but we rarely use it. And then this one is metabolized to hydromorphone. So hydromorphone is going to be more potent than morphine. We have oral routes of both IV or IR and ER, immediate and extended. This is another one where extended is rarely used. Our considerations, so again, we have those unique metabolites. So H3G is going to be that CNS effects where we can get that hyperalgesia or increase in pain. 35% of the metabolism of this drug actually turns into that. So, right, not great that we're causing more pain with a fraction of this drug. Questions with kind of this opiate-like grouping? All right, we're going to move on to oxycodone. So oxycodone metabolizes to oxymorphone. Oxycodone also has serotonergic activity. So this is different than some of the ones that we've talked about here previously. It is also going to be more semi-synthetic, meaning it's less opiate-like, right? It's going to be a true opioid. We're going to be at risk for serotonin syndrome with that serotonergic activity. We have both immediate release, either by itself or with Tylenol, and then we have extended release. Interestingly, who has seen any variety of the streaming Purdue Pharma documentaries? Show of hands. Few here, few there, yeah. So Dope Sick is one. I watched that one, very troublesome, but it talks about the whole Purdue Pharma, which is the drug manufacturer of extended release oxy or Oxycontin, and kind of how they marketed it and different things. So it's labeled and it's marketed as a 12-hour therapy. Oftentimes we do need to dose it every 8 hours because it does not work that long. And then considerations, we have oxycodone to oxymorphone. Again, C's go to M's. And then we do also have a metabolite here of that O3G that can cause that increased CNS effects. All right, jumping all the way over to tramadol now. So we're not talking about oxymorphone, we rarely use it. Tramadol is going to be a C4. It has weak action at that mu receptor. It also has serotonergic activity, so we're also going to be at risk for that serotonin syndrome. And then we have IR and ER of this one as well. Again, ER of this is rarely used. Mechanistically, remembering that serotonin, we can have a reduction in our seizure threshold with tramadol. And then we have that same 2D6 pathway, right? So thinking about our kiddos and those that are at risk of metabolism pathways with that 2D6, the ultra rapid metabolizers. So thinking about all those agents that we've talked about, let's talk to Kevin. He's our 58-year-old patient. He has an upcoming elective painful surgery. He reports historical reactions of itching with morphine and wants to ensure that his pain can be well controlled both intra and post-operatively without worsening his general tolerability. So he doesn't want more itching and rash and all that stuff. So what things might we be thinking about if he's had a reaction to morphine? Could we give him codeine? See some no's? Why not? Metabolizes to morphine. That'd be silly. We're not going to give him morphine, so we're going to avoid codeine and morphine. Okay. What about hydrocodone or hydromorphone? Potentially, right? We don't know. So likely the effects were from the morphine itself, but could they have also been from hydromorphone? Maybe. Okay. What about if we completely switched gears and went to like oxycodone or oxymorphone? Yeah, potentially maybe a little bit better, okay? Or even tramadol, okay? All right. And then Miss Anna, she is our 33-year-old breastfeeding woman. She has new onset cough, and she is associated with a viral illness, and she's hoping to just help suppress it. So if we only wanted to give opioids to help with the cough, what are our options? Yeah, codeine or hydrocodone are two C's there, good. So they're gonna be our antitussives. Are they okay for her case? What are our thoughts? She's breastfeeding. Sophomores, I'm hearing mumbles maybe. So the concern is that she now has codeine that could be getting into breast milk and is now feeding kiddo with codeine-infused breast milk. If kiddo is an ultra-rapid metabolizer and is metabolizing codeine straight to morphine, what's going to be the risk? Yeah, overdose in the kiddo, okay? All right. We're going to move over to fentanyl. So fentanyl is a C2. We have a couple slides here on fentanyl. This is also going to be a mu receptor, and then we also have serotonergic activity. It is completely synthetic. It is more potent than morphine, remembering that we have risk of that serotonin syndrome. So formulations here, we have injectable solution. This will be for acute uses and short acting. Often procedurally, we're using fentanyl. And then we have a transdermal patch or Duragesic. Chronic continuous use is going to be here. We do not give opioid naive patients the transdermal patch. Unfortunately, about 2 years ago, there were other easily administered options for folks that are nearing end of life, aren't able to swallow, potentially on their deathbed, that we could be giving products for, so sublingual products here. These have since been discontinued voluntarily due to the FDA requesting more guidance and insight from the manufacturers, and they just simply didn't want to do it. Talking specifically about these patches, I think this is something that certainly my students are always surprised by. So these patches are actually clear, they're tape-like, and they just have a very white font of what the product is and what the dose is. Okay. They're going to be placed anywhere on the outer arms or upper chest or along the upper back. They can also be placed kind of on the bra line on that side there. For women or those that are wearing bras, I don't recommend that they place it there. Any sort of pressure on that could increase the absorption or cause the sides to roll up. Patches usually are applied every 72 hours. It takes about 6 hours for them to actually start working. And like we already talked about, we just fold them in half and then flush them down the toilet. If we were to cut a fentanyl patch, think of it like a waterfall. Everything is going to come out all at once, and we're going to have an overdose event within an hour or two. Okay. Any sort of external heat exposure is a unique box warning with fentanyl. So whether that's using heating pads, blankets, tanning lamps, hot tubs. We had one of our palliative patients who every time they took a warm shower, their pain was super well controlled, right? They were on a fentanyl patch, so it kind of made sense. This increase, so even if they just have a systemic fever of about 103, that increase in dose is about 33%. So it's a significant amount. There are some fentanyl derivatives that we will see as well. So sufentanil is going to be more potent, and we have either sublingual or IV formulations of this one. And then remifentanil is a unique one in that we use it primarily in very quick procedures. It's actually metabolized in the blood, so it doesn't have to go to the liver to do anything else. We just inject it. It's in and out of the body very quickly. All right, merperidine. There were a lot of slides on this one in your last lecture series. Its brand name is Demerol. Its nickname is that we dump Demerol. Okay. It has loads of different mechanisms, including serotonin. Off-label, we're going to use it for post-op shivering, but its primary use is not for pain. If we do use it, we need to use it less than 48 hours. It has a very long half-life that's going to cause more CNS effects and seizure risks. And then because of all these different mechanisms with serotonin and norepi, we need to be careful with our MAOIs. So thinking about some of these products, if we have Alex, he's our 43-year-old who is coming to the ED and he has that presumed GI-related metastatic disease. So we already said that yes, he's appropriate for opioid therapy. How are we going to potentially treat Alex? What dosing approaches do we need to be mindful of? He just came to the ED. He's never been diagnosed until right now. Yes, we can give him opioids, but what do we need to start with? So think broadly, not a specific agent. Low dose. What other characteristic does the opioid need to have? Short acting, right? He's never been on these things before. We need to get him used to it. So we get him on a regimen of, let's say, oxy immediate release. Okay, he gets a couple doses, he feels good, he's able to be managed on that. 2 weeks later, he comes back, he's taking 8 tablets a day. Okay, what could we do then? Yeah, then we can switch him to an extended release, right? Here's your fentanyl patch, it's gonna help maintain this ocean that you have of your pain. You can still have some oxy. Hopefully we don't need that much anymore, and maybe you only need 2 or 3 doses a day moving forward, right, for those tidal waves. All right, good old Josh, he is your 34-year-old friend, and he cares for his elderly mother who is actively receiving the support of hospice. Her pain is well managed with the use of fentanyl patches and concentrated morphine oral solution. So again, she has something for the ocean and then something for those waves of pain. She's been feeling down recently, and so Josh hopes to cheer her up with a heated blanket. Such a nice son, right? Okay, so again, these are cases that are not unheard of, an easy, quick thing to just have those kind of buzzwords in your mind to be thinking about when you're talking with folks and talking with friends, certainly, about certain situations. So the concern here is that we have a heated blanket with a fentanyl patch. Now, if it's placed on the patient and the patient's total body temperature increases, and certainly if it's applied over the patch site, that is another concern for increased absorption and then potentially accelerating that death process. All right, so a couple slides here on methadone. We talked about it already. For which condition could we use methadone for? Opioid use disorder, okay, so that's substance use disorder with opioids. We have many different mechanisms. So methadone's primarily going to be looking at different opioid receptors and all of them. We also have that NMDA receptor antagonist, so that revving process. But now we also kind of have this antidepressant SNRI process as well, so serotonin and norepinephrine. So it can be a really useful tool when we're using it for pain because we're kind of encompassing a couple different agents all in one. When we use it for pain, primarily it's going to be useful in kind of mixed neuropathic type conditions. Usually when we're dosing for pain, it's going to be less than 40 milligrams a day. This is just a generalization. You don't have to know that dose for the exam. When we're thinking about it for opioid use disorder, these are going to be doses greater than 40 milligrams a day. So whenever a doctor says that, hey, I have a patient, they have pain, I'm using methadone, they're on 30 milligrams a day, I get nervous. Okay, it sounds like a low dose, it is not. Okay. For opioid use disorder, we have folks that are in hospital that are on anywhere from 120 to 500 milligrams a day. So much, much different when we're treating it for that. And then again, those have to go through that outpatient clinic to get those doses. Cool. Multiple different routes for this one, so both oral and injection. Half-life goes anywhere from 8 to 60 hours. Love it, hate it. Wish it was a little bit more narrow of a window maybe, right? Really wide range, right? Do you have to do three times a day until it's gone, or 4 days? That duration increases with increased use. Usually we dose it either 3 times a day or twice a day. The peak effects with methadone are going to take 3 to 5 days with continuous around-the-clock dosing. The dosing is complex and the conversions are weird. You should always ask an expert for help. Remember that methadone is one of our ones that does not have active metabolites. It has many inactive metabolites, and it goes through nearly, 5+ different CYP receptors for that. Okay, so any change in a CYP enzyme is likely going to increase the amount of methadone in your body. All right, naturally it's a long-acting. The benefit with that is that we have minimal withdrawal effects if it's stopped or missed. So if you have a patient who's maybe not the most able to remember some of their medications, it can be really helpful in that situation. Additional unique side effects with this one, so that serotonin syndrome, QTC prolongation is a unique one that is dose dependent. This is a snippet from, so we don't have a newly updated guideline, but we have a 2019 white paper that is just an expert opinion paper that was a panel of folks that say, yeah, we probably shouldn't use it as a first choice opioid unless folks are familiar with how it's used. So bottom line, it has a unique risk profile, and make sure that you collaborate with experts if you're using it. So if we have Ken, he is our 74-year-old male. He's admitted because he has an exacerbation of pain, and he's previously been well managed on methadone 5 twice a day. Despite increasing the dose yesterday in-house to 7.5 twice a day, his pain is still poorly controlled, and the team decides today to increase it to 10 twice a day. Totally fine, sounds good. Who says that it's good? Love it. Who says it's not great? Okay, seeing a couple not greats, why not? Yeah, so the half-life is really long. We have not hit steady state yet. So other medications, we hit that steady state pretty quickly. Methadone, we're not going to see the effects for 5 to 7 days potentially. Usually we're not dose changing until 3 to 5 at the very earliest. Okay. All right, questions with methadone? Lots of different mechanisms. Sole active agent, no active metabolites. All right, bupe. So bupe we have already talked about as well. Again, this can be combined with naloxone. The naloxone is just to serve as an abuse deterrent if you were to take the pill and try to inject it, but it doesn't have a very good oral bioavailability when it's used. So buprenorphine's mechanisms, we have mu partial agonists. So again, that's just that one saloon door that's open. Only part of those effects are going in. We have delta antagonists, so we're just occupying that receptor. And then we have that kappa inverse agonist. So that, why can't I think of it? Not euphoric effects, dysphoric. It's not what it is. I'll think of it. But we're having that opposite effect, so less of that CNS risk with that kappa mechanism. And then NMDA receptor antagonist. When we think about this partial effect, what is that actually doing? So we have this reduction. This is somewhat above you guys, but just if you're interested in this, with normal opioids, we have this phosphorylation that comes in, and that causes all of our side effects. So when we have a drug bind to a receptor, all of these little phosphates say, yay, let's party, and that's how we get our side effects. When bupe binds, because it's not doing that full mechanism, we have less of that phosphorylation and therefore less of those side effects. Bupe also has the highest affinity or magnetism to the receptor, meaning if you're taking any other opioid, bupe is going to say, no, that's mine. Okay, and it's going to sit in its little throne on that receptor. So it's always going to kick other things off. Usually, though, this is not happening until folks are on greater than 16 milligrams a day. The current guidelines for when we use opioid therapy in chronic pain say that we should be using buprenorphine instead of other full opioids. So if I have chronic low back pain, and now we're in that fourth criteria of when opioids could be effective, which is going to be in that severe refractory chronic pain, and we need to pick an opioid, we should be picking bupe. Okay, so my hope is that when you guys are practicing, the folks that you see that are on opioids, my hope is that they're on bupe for their chronic pain. Okay, again, the guidelines also say we shouldn't be using opioids. If we do, it should be bupe. Okay. How we dose. So low doses are going to be for pain. We only need to be occupying a very small amount of these receptors in order for that pain benefit. When we do moderate dosing, so this is anywhere from 2 to 16 milligrams, we're occupying at least half of those receptors. And this is where we're going to talk and inhibit those cravings that are happening. So this is where we're targeting that opioid use disorder. And then at our higher doses, or greater than 16 milligrams, also for that opioid use disorder, but this is actually going to block the effects of any other opioid that we're taking. So if you are then going to use heroin, it's not going to work. Okay, bupe is on that. It's not going to be able to bind there. Similar with methadone, we do have QTC prolongation, which is dose dependent. This one here is just an FYI slide, but it's just another way to picture those 3 different criteria. So usually the agents that we're using in chronic pain are going to be dosed in micrograms. So most of my patients I have on 5 to 15 micrograms an hour, or less than 600 micrograms of the films. When we're talking about opioid use disorder, these are going to be in milligrams. Okay. So if we have Noah, he's on bupe 900 micrograms a day, and he's scheduled to undergo an anterior cervical discectomy infusion. Super fun. And the post-op pain is expected to be severe and last for a couple days. Do we have concerns, right? So this surgery that he has upcoming, can he get opioids for that surgery? If that was the only criteria. Severe acute pain, procedural related, yes, he can get opioids. Do we have concerns with a dose of bupe, 900 mics a day, that he's going to have issues co-using another opioid? 900 micrograms. So 0.9 milligrams, that is much less than 16 milligrams a day. So we're not going to kick off any other opioid that he were to be administered for that acute post-op pain. Okay, so we can co-administer. He can maintain his bupe. That is currently what the anesthesia guidelines suggest and the surgery guidelines recommend, that anyone who is on bupe maintain to be on bupe unless they're above 16 milligrams, in which you would reduce their dosing to be at 16 milligrams or less. And then you can also add fentanyl during the procedure, that's fine. You can do hydromorphone, Dilaudid, whatever recommendation that your team wants to be doing for those things. He is well able to be co-managed with both of those products. So thinking about kind of some of these pathways, remembering that we have different metabolism and excretion pathways. Many of these opioids are connected and similar to each other. Short-acting opioid therapies usually peak and reach that plasma concentration in effect within 1 hour, and then those long-acting therapies can take hours to days. Many other opioids have additional mechanisms, so think about the ones that have serotonergic or unique receptor sites at those opioid receptors, and therefore they have different side effect profiles. Questions with specific agents? All right. So last section here are going to be our opioid dosing considerations. So this is how we do different conversions, rotations, and tapering. So more so the principle of it rather than knowing specifics of how do you dose morphine. Okay. When we think about our opioid therapies, we use a common language in terms of oral morphine equivalents. So these might be reported as MEDDs or morphine equivalent daily dose, the equivalent dose, the milligram equivalent of oral morphine, but they're all related to morphine. So I can say, yep, this person's on oxy, their MME is blank, and that's the dose that it would be if it was in morphine. Okay. There is no definitive way or calculation that these have been determined. So we just continue to get some data, and some expert says, you know what, I actually think that oxy is 2 times more potent than morphine. So we should do a factor of 2 times. And someone else says, no, it's not. We should do 1.25. And so we're just trying to compile all these things to make our best guess to correctly convert and make all these things kind of on that same playing field. There are many online calculators that you can find. We in the DHA typically are using a CDC published calculator back from 2012. Not great. There's been newer ones that have certainly come out and other suggestions. DHA is a little bit behind on updating those things. As with any clinical practice, it takes about 17 years for anything when it's published in guidelines to become clinical practice. So we're close, we're getting there. So the table that I will have you guys use will be this one. You do not have to memorize these columns here. This will be provided to you, okay? This will not be included. This is just to help you guys understand. So when the numbers are higher, that means that they are less potent and they're weaker than morphine. You need more of it to get the same effects that you would of morphine. We talked about how morphine and hydrocodone are equally potent. And then all these other ones, you can see that their numbers are smaller. These are going to be more potent. You need less of it to get that same effect. Okay? These are equivalent doses in milligrams. Okay? And then this table is as such because these are typical daily doses that we might expect and are often easy to convert. So tramadol, this would be equivalent, right? If someone's taking 50 TID is a common sig that we would see, and so it's straight from the table. You don't have to do a ton of calculation from that. Okay. The 3 on the bottom there, so fentanyl, methadone, and bup, per the 2022 guidelines, we should not be calculating them. Okay, so it's either too confusing, there's too much risk for error, it's not linear conversions based on what dose that we're at. And so those ones we will not be calculating, and we need to make sure that we're being cautious whenever we're converting for those ones. So let's say we have Mike. Mike is prescribed oxy-IR 10 milligrams by mouth every 4 hours for severe pain post-op, and yesterday he got 4 doses of oxy. And I want to know, what is his MEDD? So first question is, what is his milligrams of oxy? How much did he receive yesterday? 40 milligrams of oxy. Okay. So then we're going to say, okay, this table says 20 milligrams of oxy is 30 milligrams of morphine. So if we have 40 milligrams of oxy, 60 milligrams of morphine. Okay. If you want to do dimensional analysis, this is how it would be shown. Questions on just a straightforward conversion? As a reminder, I do have that separate worksheet to go through multiple different examples if you want to try doing this conversion both from weaker agents, right, less potent options to more potent, vice versa, all the different ways. The first section of that is just going everything to morphine, and then the second section is going one opioid to another opioid. So kind of bypassing morphine, or as I often do, take it to morphine and then take it once again to that new drug. Okay. All right, if we have Dave, he has chronic myofascial low back pain, and he's prescribed hydrocodone with acetaminophen. That dose seems wrong. 20 okay, so it's a 10-325 times 2 milligrams Q6. So if you guys have never seen combo drugs, right, this 20 milligrams is resulting in this hydrocodone. This 650 is with the acetaminophen or the Tylenol. So when we're calculating the MEDDs, we're just doing the hydrocodone 20. But first, he's saying that this regimen for his low back pain is less effective than it used to be. What is that term suggesting? That he is tolerant, right? He has tolerance. Okay, so then what is his MEDD? Did I change this and I didn't change my answer key? So if we have 20 milligrams of hydrocodone, we take 4 doses a day, so don't get tripped up on Q6, meaning 4 doses. It's a 30-to-30 equivalent, or a 1-to-1. So we're going to have 80 milligrams of morphine a day. Okay. So then let's talk about a few more terms. So opioid rotation means that we are then switching from one opioid to another opioid. Okay, so we're on hydrocodone, but now we want to go to oxy. So tolerance, as we've already talked about, is that decreased efficacy, and we need to increase that dosing to get that same benefit. Cross tolerance is a very broad term that describes that there are similarities among different agents, specifically in the same drug class. Incomplete cross tolerance accounts for the dose reduction that we need to take when we rotate from one opioid to another opioid, because we expect there to be some pre-tolerance to that drug already, right? Our mu receptors know what an opioid's like, but they don't know exactly what oxy's like, but it knows it a little bit, okay? So this is just saying that when we go from one opioid to another, we need to be dropping that dose a little bit because we're somewhat familiar with it, but not completely. This can be a way to leverage, okay? If someone's wanting to reduce their dosing, we can actually just we can rotate to another opioid, and by default, it reduces the dosing, okay? Because we're going to reduce and adjust for that incomplete cross tolerance. So this is from the guidelines here. So we never use, and this is just to reiterate what I just said, right? We never use the calculated dose from one agent to the other when we're determining that conversion. We always want to make sure that we are lowering that dose, and that is due to that incomplete cross tolerance. Generally, the approach that we do is a 25 to 50% reduction in the setting of controlled pain. So if my pain's controlled and you want to put me on a different one because now the pharmacy's out of stock of morphine and now I need to be on oxy, okay? You are just, my pain has been controlled. You need to dose reduce me to my new oxy. A caveat to this is if it's the same opioid, but it's a different route. So if I was getting IV hydromorphone and now I'm taking oral hydromorphone, we aren't dose reducing, okay? And that's just because it's the same chemical. Okay, so if it's the same opioid, just a different route, we don't do any dose reduction there. The extent of that dose reduction, whether we choose closer to that 25% or 50%, is going to depend on the amount of tolerance they have. If someone's been on a medication for 3 months versus 30 years, there's going to be different levels of tolerance that they have to those agents. Okay? The extent that you guys need to know for the purposes of your exam is not going to be tested. Okay? Just knowing that it's that range, that 25 to 50. The general approach is that we'll calculate that total daily dose as we did, We'll convert it to our morphine equivalency using our charts. We'll then dose reduce by that 25 to 50%. We'll then convert it to our new opioid, and then we'll create a regimen. Okay, so if it's at 80 MEDDs, now we dose reduce to 60, and then we're going to go ahead and figure out how do we divide that up throughout the day, right? Is it 10Q4, whatever that new opioid is. This is an example if you want to kind of see it spelled out, rotating tramadol to hydrocodone. So then if Dave is taking this hydrocodone, and we want to rotate him, we're going to go ahead and do a 25% reduction, which I didn't realize I was just giving away answers, talking too much. Okay, so 80 MEDDs, now we're going to reduce that 25% to get that 60 MEDD. If we want to then convert to oxy, okay, now we can take our morphine equivalency here is 30 milligrams to oxy is 20 milligrams. So do we want a bigger number or a smaller number? We'll want a smaller number because the table has it as a smaller number. So regardless, on the exam, I hope that we're not picking bigger numbers because they'll be there. Okay? All right. So if we do that conversion, our total oxy then will be 40 milligrams of oxy. Okay. But should we really even keep Dave on opioids? Right, he has chronic pain. They weren't really working. I don't know. So if we thought about maybe tapering, opioid tapers or weans are when we reduce that total daily dose. It depends on the situation and what the goal is. Okay, so if some people hope to eventually discontinue opioids, that can be a way that we, approach it. If the hope is that they get down just to a certain cutoff or amount, that can be our goal as well. The guidelines, so these are the VA/DoD guidelines. They suggest using some sort of collaborative approach with your patient. So don't just tell your patient, hey, we're taking you off of these. Work with them. And there's no true recommended way of how to do it, so long as it's being done, okay, if we're choosing to taper. The CDC guidelines do offer a little bit more data as to how to go about doing this. So long as the benefits don't outweigh the risk, it's appropriately, how do I want to phrase this? Right, so if the risk is too high, we should be tapering. We should not stop them abruptly unless there is concerns for they're selling their opioids, they're not even taking them, right? They're doing other things that are inappropriate or that are at risk that is life-threatening for a potential overdose. So are they crushing up their oxy and injecting it, right? Probably we should be a little bit faster, okay? We need to use that shared decision-making, and then usually the approach that we use is reducing 5 to 10% of their total daily dose every 2 to 4 weeks. For those that have been on therapy longer, we're going to use smaller changes and more or less often changes. So one of my favorite questions, so in clinic I usually get folks that have been talked to their doc and they want them to be tapered off. I'll meet with them. And it's always interesting to me as far as what their goals are with tapers. Okay, and oftentimes patients are like, oh yeah, I've been on this 30 years. I could be off in like 2 months. Like if you were drinking 30 cups of coffee a day, do you think the next 2 months of your life are gonna be good, right? Do you still wanna like do stuff? So my goal is usually 1 year to 2 years, right? Because I still want them to be functional. I want them to be doing stuff. And then we're gonna prioritize minimizing any sort of withdrawal that they could be having, right? So if they have diarrhea, giving them something that's gonna help mitigate that. So Dave, 1 year later, he's now 58. He's, oh, I didn't even put it in there. He's on that oxy 40 milligrams a day. And he says, you know what, I think it's time that I stop these. They're too risky and they're not helping as much as my other pain modalities, and I'm just worried about that withdrawal. So what things might we think about with Dave or talk about? What approach could we be using? So we're going to taper. How are we going to taper? Slowly, that 5 to 10 every 2 to 4 weeks, right? Unless he's doing something crazy with them, okay? He's at no immediate danger to himself, so we can gradually do it. And then also thinking about what is the formulation that you have available to you, right? So Oxy does come in an oral solution. Do we need to rotate to that to get that reduction? Can we do half tablets? What's the best way to go about it for that patient? So wrapping up here, clinical pearls, opioid doses are going to be expressed in terms of oral morphine equivalent. It's paramount to make sure that our reductions, when we rotate from one to the other, when we have that rotation, to account for that incomplete cross tolerance. And then taper approaches should be patient specific and then also manage any sort of withdrawal symptoms. So to totally wrap up, CDC guidelines have these kind of 12 tenets. This is a FYI slide, but it very much just summarizes and speaks to many of the things that we have covered as well. Remembering our opioid response curve when we add our opioid and then take it away. And then there are plenty of additional resources for you. These are beyond those that were in the very intro slides. So clinical pearls with opioids, there's utility for them in select pain scenarios. We need to actively consider differences in their mechanism, their potency, the pharmacokinetics, renal and hepatic side effects, and then different dosing approaches. Making sure that we're thinking about both tolerability and the safety of opioids, and then encouraging that active engagement with the patient when we either need to rotate to another opioid or start a taper and potential discontinue. Questions? Remember, there are online resources. Hart told me that you guys didn't have access to the memory jogger slides. Wish I would have known that. She should have uploaded them during class. So you have those. Know that there are memory joggers available for these last opioid sections as well, so you can work on those to help guide studying. And then certainly those different worksheets and handouts. Questions? Have a happy and safe 4th.